Today we have a very esteemed panel. I think if you look at all the panel members here today, you couldn't look for a better opportunity to get input from some of the key leaders in Pakistan. So today we are really going to focus much more on treatment. Now, one thing I've said to the panel members earlier, we had a discussion earlier in terms of where we want to focus. So one key thing we agreed to is that we are going to focus on very pragmatic, realistic strategies around two most important things. The first thing is creating an optimal experience, patient experience. The second one is how do we deploy smart institutions, smart technologies. Now, yesterday we had a lot of discussion. Some of the technologies that are coming downstream are quite, to be frank with you, could be very opportunistic, create great healthcare, but there are real dangers to generative AI. We discussed all that. So there are real opportunities in this whole space. So we want to discuss that in a very pragmatic way for Pakistan. So today we are going to focus on those two major issues. One of the things I requested the panelists is I'm going to push you as chief executives, because you are the chiefs of your organizations. Each one of you deploys different health systems, different reimbursement mechanisms. You treat different populations. You think about affordability in a different way. So one thing I've told the CEOs is that please do not agree or disagree with what the others are saying. We want to hear your original input. What are you doing? What are some of the aspects you have in terms of really looking at optimal patient experience? Give us your points of views, given that there's a diversity of the way you think about it. So hopefully, inshallah, today what we'll get is real input from the chiefs who have to think about these things, because these are the gentlemen who really have to put together the systems and think around all the issues we discussed yesterday. Now, today we're going to focus much more on treatment. Now, one thing I have also asked the panelists to do is, even though we're not focusing on the issue of affordability, but one thing that became very clear yesterday is affordability and access is an issue. So we are not going to be sidestepping it. It's just that because we don't have much time, we're going to focus much more on the optimal patient experience and how are they thinking about a smart hospital? What does it mean in Pakistan? Now, one quick comment I'm just going to make, because my role is moderating these chief executives, but just one observation is this issue of patient experience, creating patient-centered care, affordability of access, equity of access is an issue anywhere you go, everywhere you go. I'm currently working in many different jurisdictions in the world, and this is a central issue each country is dealing with. Even some of the countries which are, you would call them wealthy countries, are still dealing with the same issues. So today we're going to talk about those things. As chief executives, I'm going to push back on certain things because I want the attendees to really understand some of the issues you're facing. How are you looking at the whole question of treatment and the whole question of optimal patient experience? So with that, Dr. Farad, why don't we start with you? Since you're sort of the first one there, let's talk about the whole question of optimal patient experience. What does it mean to your system? How are you dealing with it? And in a pragmatic way, how are you looking at the whole question of patient-centered care? And if you can even briefly talk to the issue of affordability. We don't have too much time today, but let's start with that.
Thank you, Salim. I was hoping that you would come to me right in the end. That's why I sat all the way in this chair. So I wanted to actually follow others. But anyway, first of all, I must congratulate Shaukat, Ali, and all of them for really putting this amazing conference together. Just speaking from a patient care perspective, and I was going to build up on discussions which would follow, but let me start. In healthcare, our core focus, and as many industries call core business, is essentially care, patient care. Now, so a lot of times, which I see and we foresee this thing happening, a greater risk, is the care component, first of all, is not well understood. And the care component starts getting diluted with many interventions which you think are going to improve the care. Care must be perceived both from the provider's perspective and also from the receiver's perspective. All of us who are sitting in the room, I think if you ask us that if you were to go to a doctor, to a healthcare facility, what are the things you're really looking for? I think they're looking for very personalized attention. they're looking for easy access, they're looking for a kind of a quick turnaround, less bureaucracy within the system, and a pure interactive time. They need to understand what the issue is, and they need to walk out, and then the whole thing to follow. So if you start looking at the definition of medicine, medicine itself, what it says is art and science. So the art part, my worry, which I'm a practicing physician myself, I see the art part getting eroded. And just a lot of times and this thing, I have spoken with tons of people who have gone to some of the finest institutions, and Salim, you know the global system extremely well. When they come back and they describe their experience, usually they don't talk about the fancy architecture or a lot of gadgetries which are there and all that. What they talk about how they were spoken to, how they interacted, how they understood, and how they were dealt with. So what I'm trying to at least convey one point, everybody will talk about many other technological aspects, is continuing to pay attention and focus on the care component. And I think we, in the entire process of implementing so many advances and so many diverse components which provide healthcare to a group of individuals, this personalized attention aspect is getting diluted and sometimes is forgotten. So I would like to bring to the audience the prime focus, and I think Miraj Shah sitting here, he's leading an exercise which is Plane Tree. We are trying to understand Plane Tree is one organized way. Essentially, that's emanating out of thinking in the West that fine, we have done all those various things which have done advancements in healthcare. But in this entire process, somehow the focus on the individual patient is getting diluted and getting less attention. And we can give tons of examples. So from an organizational perspective, we've gone through the Joint Commission and we follow all the things. We invest on everything. We have gone through CAP and everything. And now we're trying to focus again on the Plane Tree component, which Plane Tree essentially is trying to focus on the care side. What is crucial? So if a person walks in and gets into the campus, how easy it is for him or her to get in, how easy it is for him or her to actually find a parking, how easy it is for him or her to find the correct signs. That's from an infrastructure perspective. And I'll just give you one very short story, and then I'll pass it on to the others. So I was treating one patient who was visiting from Australia. And, we were just trying to take the history. And this gentleman said, it's after decades that somebody is actually looking into my eyes and talking to me. I said, what do you mean? He said, in our health system, it's wonderful, everything. But everything is computerized. So usually the way a physician sits, he sits diagonally to me. He's only looking at the computer screen. He's typing and he's listening from this ear. And I sometimes wonder if the hearing is right, is correct on this side or not. So he said that for the first time, I said. So that gives you the human side. And again, I will say the first and the foremost thing, the innermost circle is around the care. It's a very personalized interaction between a physician and a care provider, and the entire ecosystem around it builds around it, not displacing it. Thank you.
Thank you, Dr. Farad. Before we proceed, in fact, what I'm going to ask each of the gentlemen is if you can just give a quick introduction to your organization. We'll just go sequentially. The other thing is, before you go, Aziz, we have the Minister of Health who was late coming in. He's going to be coming here soon. Did you want to pause for that, or? I
think we can continue. When he comes in, I'll request a 2 minutes pause just for welcoming him, just a standard protocol. Yeah, thank you. You can carry on for now.
Thank you.
Thank you.
So let's proceed. Next gentleman. Same question, by the way.
Thank you very much, Salim. I'm fortunate sitting in between two eminent healthcare leaders, and it is difficult to express sometimes when I'm sitting with Dr. Bari. He has been doing a wonderful job, and Dr. Farad, my mentor as well. Salim, as Dr. Farad alluded, I'll take out from there. The patients in a hospital setting is looking, or any of the setting, whether it's a hospital, clinic, wherever it is looking towards the patients or the doctors or the health providers, that how he has been looked after. I'll give you my own example. Recently, I had two incidences. One was I took my wife to one of the hospital, my own hospital in Islamabad. They have recently started this using computers, history and all that. And they know me very well, and then chit-chatting, and then and then my wife said, Aziz, no, let's go to somebody else, because he was not looking after, he was not listening to us, he was on the computer. The second part, I was in Turkey last year in summer, so I had some similar thing, ear infection. I went to a hospital, and the doctor was looking at me, and he was talking to me directly, and then everything was, and he had a mic, and everything was typing. So the technology can bring a lot of innovation and ease to our life. I think the important thing is that how we can consider the patient-centric areas. I'll give another example of this practical. When we were doing, providing the medications through these paper pieces, right? So there was a lot of mistakes were happening, thousands, and sometimes look at in US that they around 50 to 60,000 people die just because of the medication errors every year. But here we were thinking, no, we don't do mistakes, we are perfectly okay. So we did a study in Kabul when I was there previously. So our medication errors were around 7%. We looked into around 60,000 files of the patients. But when we implemented bring the technology, that has drastically reduced, but still we are making mistakes. So what I'm saying is that I think the patient is coming to you for, as Dr. Saab said, that one is the technical part which you are providing, whether diagnostics, medication, whatever you do. On the other side, how you are receiving the patient from your gate to reception, and how you are sending him back, and then what you are following. So my own understanding is the technology can bring a lot of innovations and everything, but I think we need to understand the needs of the patients from the perspective of being a human being first. It is not about just a patient, it's not an equipment, it's not a machine. So we are dealing with the human, so the human, that area has to be. The second thing is, from the perspective of healthcare providers, quickly, is that we need to provide them tools to ease their life. The workload is so much. Workload is so much. If I ask my team, they will say, sir, it's too much of writing from morning to evening. So I think we need to have a balance between this and how the technology can help us to bring that forward, so we can have a better outcome for the patients and the satisfaction of the patient. Thank you.
Thank you. We'll just continue this way. So if you could just quickly introduce yourself and your organization.
Bismillahirrahmanirrahim. First of all, thank you for giving me the opportunity to be here amongst these panelists, esteemed panelists. I'm Dr. Abdul Bari Khan. By profession, I'm a cardiac surgeon. But I am the founder of Indus Hospital and Health Network, which started in 2007 as a paperless and a cashless hospital, no cash counter. And why we are doing it? Because we were trained in the public sector hospital. We have seen the plight of the patients coming there, poorest of the poor coming there, where they used to have doctors and bed available, rest it was out of pocket. So every patient had a story, selling their cows, their goats, and their all belongings to get simple treatment in a public sector hospital. So I haven't heard many patients, many parents saying, let them die, because it's better to get rid of him and save 8 back at home. So that was the why. And we started as a paperless because we knew in the hospital, civil hospital, thousands of patients coming in. We used to prescribe them, get their test done, but in the next visit, we don't get anything. They don't have their x-rays. And if someone brings it folded, and when you open it up, there were stains of tea, and Greece on it. So we said we will, at that time, it was the vision, we will start with a paperless hospital. If someone wants to come in, they have to follow. It's either way or highway. So they had no other option to have a paper. When we were fortunate because we started from the beginning. About the patient, what the question which is, I just say very simple. A quote from, ayat from Surah Baqarah, Inna Allah yuhibbul muhsinin. Allah loves who believes in excellence. And what is the definition of excellence? I was wondering. I questioned many people, both worldly and religious people. I couldn't get the answer. And one day when I was reciting the tafsir, and I got this ayat. And in worldly man, in your religious, so you offer your prayers as if you are seeing the Allah subhanahu wa ta'ala. Or the least of it is, at least you see that He is looking at you. And for the patients, so what you like for yourself, you like for your brother or the fellow citizens. So it's very easy. Put yourself in the boot of the patients, and you will make it. So we said quality care, free of cost. And the benchmark was we'll have also our treatment there, in our hospital. It is just not a slogan, quality care, because if an owner of a hotel eats in his hotel, then the quality of food is good. So it was, my mother-in-law had pacemaker implanted in that hospital. My director of anesthesia, he got his bypass surgery in that hospital because he could afford anywhere in the world. He was an American citizen, but he said, we will have it there. So, very simply, if my kid has some pain, I want immediate relief. And I should provide that to others also. Thank you.
Thank you, Dr. Barry.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Ehsan Siddiqui, and by training, I'm a pulmonologist and public health physician. Currently, I am working as a CEO of the Sindh Healthcare Commission. Sindh Healthcare Commission, likewise, in every province we have these commissions who are regulator, and we are supposed to regulate the practices of the doctors as well as all healthcare establishment, whatever they are. So our vision and our horizon is big. So we are dealing with the public sector hospital as well as we are dealing with the private sector hospital. There's a drastic difference between these two entities. Because the public sector hospitals, these hospitals has got a hierarchy, which is 77 years old. It is manned by Secretary Health, the DG Health, and all those things, and they are regulated to a bit. And they have got a structure which starts from a basic health unit, a dispensary, to rural health center, taluka hospital, the civil hospitals, and likewise. While when we talk about the private care setting, we are talking about thousands of school of thoughts, thousands of business ventures, and thousands of hospital and healthcare establishment as per se. So it's a diverse private sector setup in the country which we are trying to regulate. So it's a humongous task. So a private sector hospital or a healthcare establishment means that you start from a general practitioner, a family physician, up to a tertiary care university teaching hospital like AKU. So this is the whole spectrum which you have to look around. Now, having said that, and with this introduction, our vision to look at these things we talk about, our mandate is to establish the equity, the quality, and to establish those standards which are acceptable worldwide as an international standard. But there are times when the people or the hospitals or the healthcare establishment, when they got licensed, be it JCIA or it's Sindh Healthcare Commission or any other accrediting body, the quality, they then try to hide behind these licenses, which is not good. Because the quality which I am talking about is what Bari was saying and what Dr. Farhat was saying, that is the art. And I always said that quality is an inborn genetic error. which is here. So when you empathize, when a doctor empathizes and consider the patient as one of his or her family member, the quality automatically delivers. But if you take patient as a subject and try to these things, it will never happen. Why so? Because at the basis and our curriculum, we never teach about quality. We never teach about communication. We always teach about treatment of disease. We do not teach about patient care. We do not teach about how to treat a patient, because two patients of the same disease will have different ethnic background, will have different belief, different religion, different demography, different socioeconomic status. So they will be different in all aspects, but you cannot treat them equally. You have to manage your care according to the need of the patient. So quality will only be delivered when you understand the need of the patient. Until unless you try to hide behind the guidelines of treatment of disease, it will become difficult, because patient perceptions are totally different. So my message is that if you want to build any type of smart hospital, or whatever you call it, you have to start from the curriculum, at the level where you are teaching them. You cannot impose something, because why people are not practicing quality? Why people are reluctant to follow infection control practices? Because these were not part of our curriculum. These were not part of our curriculum. So communication, quality, infection control, smart hospital, digitalization of your healthcare, it should all be part of the curriculum. Until unless you ingrain these things in the mind of the student at the beginning, you cannot expect them to deliver at the time when they are a doctor. Thank you.
Thank you.
Thank you very much for the invite. My name is Shafiqur Rahman, and I represent Rahman Medical Institute. We're a tertiary care hospital based in Peshawar, which is also an academic institution. We have 5 colleges with a total student strength of about 2,500 students, running 16 different undergrad programs, and soon to be a chartered university as well. Coming to the subject, and just for a background, the whole vision for establishing RMI was Peshawar didn't have a tertiary care hospital serving a lot of different specialties for which patients had to travel all the way to Karachi and other cities. And it is with that vision that our founder chairman, Professor Mohammad Rahman, established the institute so patients could have quality care at their doorsteps. We see, at RMI, we see patient experience as really the sum of all interactions that a patient has with healthcare throughout the complete continuum of care. And with the hospital now being just one component of the overall health experience, that does not start when the patient arrives at the hospital, and it does not end when the patient leaves the hospital. The touch points are well before that, and the continued interaction happens well after that as well. For a smart hospital, in our experience, I think EHR, or the electronic health records, sits at the very heart of the continued patient experience. There's so many occasions where patients would come and tell you, I answered a whole set of questions only to be asked the same again 10 minutes later on. Or for someone else to come in and ask me certain allergies or dietary preferences and so on. Capturing information in a manner which is accessible to all the stakeholders involved in delivering that care is absolutely critical. And you talked about affordability, which I think is an extremely important aspect to all of this as well. There's a lot of innovative solutions available out there, but you would always want to evaluate them against affordability and evaluate them, their effectiveness against affordability as well. I think in Pakistan, or at least the part of Pakistan that I represent right now, we have an amazing opportunity. Paper records, and we just discussed that a while ago as well, paper records, more so on the outpatient setting, have been non-existent for a very long time. Patients come in the outpatient setting, they have all this interaction, medications, diagnosis, all of that, and it's just jotted down on a piece of paper that leaves them. And in recent years, we've seen an explosion of all of these solutions that have come to the market, which allows you to really leapfrog a whole generation. So going literally from 0 paper records, you can jump onto electronic health records. And that's the transformational shift that we are seeing in our organization in the wider healthcare ecosystem. The other way I look at the smart hospital or the patient experience and how an integrated smart hospital looks at that is it's not one massive intervention that makes a difference. It's really the sum of hundreds or thousands of smaller interventions that shapes the overall patient experience. Just to cite one very small example of something that we did a couple of years ago, and we get patients from very diverse backgrounds, from all parts of Afghanistan, from northern Pakistan and elsewhere, speaking a range of languages, different dialects, and for them to be able to communicate with someone in that language matters a lot. So the fact that you capture a preferred language in your system and make that known and accessible to people from your call center, to people at the front desk, to all the care team, makes a world of a difference. You've got people interacting and better understanding the needs of the patient in that language. I used to joke with my team before that. I said, Pizza Hut knows me better than we know our patients. I call them and they know what kind of topping I like, where do I live, and what I ordered last time. They just reconfirm if it's the same that I want. And this is what we've implemented. So a patient calling in, the call center agent would know when was the last time the patient came in, what language is a preferred language, and they would connect to the relevant agent, what they're likely to ask for, which clinicians they've seen in the past. And just that personalized experience with the patient takes things to a whole next level. It's all of these little interventions that matter so much to the patient. I mean, looking at it from the patient's perspective, of course, quality care, high quality care is extremely important, but it's the sum of all of these interactions. The surveys, the feedback, hearing back from the patients, and it's just a continuous feedback loop. It's a continuous learning system where you incorporate all of those lessons learned, all of those feedback that you obtain in seeing how you can improve the delivery of care and on an ongoing basis. Thank you.
Thank you. So I'm going to take a quick poll with you. I think quite a few observations have already come up. So one key observation is that any hospital, whether it's public or private, now has no choice but to go with some form of electronic medical record that integrates digitally everything. We've been talking for 15 years, 20 years about how avionics change safety, how can we bring it to healthcare. We talked about banking. You can get all your data, everything, right? In a banking, how do we bring it to healthcare? So how many of you really think that we have a choice now, today? And yesterday you heard about AI, you see the potential for AI. So how many of you really see this electronic health record, in whichever way you see it? Amalgamation of all the data for all the patients, so you know everything about the patient. Now, whether you share it with the patient or not is another question. We'll come to that. How many of you feel that today, every public and private hospital really has to go to some form of an electronic health record where they can then create mechanisms to be able to find out what the patients are going through, what patients really need? How many of you feel this is an absolute 100% necessity? Show of hands. Okay, so most of you agree, right? That's really important. Second thing we discussed today is that there are, in healthcare patient experience, there are many, many touch points. Now, Ali showed that photograph to you early. Communication issues. Patients don't feel they've had enough interaction. Sometimes I think sometimes only, we forget that in healthcare delivery, it's a very complex process. These are the most sophisticated, complex organizations you can come. There's everything going on. So, question is, there is a multitude of people that interact with the patient. And as we said, there are many, many touch points. Sometimes we forget the allied health professionals who do the diagnostics, people who greet you and meet you, people that come and clean your rooms, disinfect your rooms, physicians that interact with you, nurses that interact with you. So my question to you is, if you look at the total ecosystem, generally, do you generally agree that it's the entire ecosystem that creates that patient experience? Because sometimes I notice it in many conferences I go to, we focus a lot on what we think is the most important. It's a crucial component, physician interaction, communication, really important. But do you feel that sometimes we forget the rest of the ecosystem in terms of the touch points, the many, many touch points? And again, you don't have to be correct about this. Don't worry about your manager who's sitting there. You're all leaders here, right? How many of you generally feel that sometimes we focus on just a segment of the healthcare delivery system, and it's more the specialist physician part? Sometimes we include the nursing part. Generally, do you think we forget the rest of the ecosystem? Show of hands, if you think so. Okay. So many of you think that we really need to focus on the total ecosystem. So to summarize what you said in patient experience, some of you use standards. Excellent to use standards. Many touch points, a complex system. Some of you have gone with a system where there's no cost. It's free of cost. Some institutions have, I think at AKU, you have mechanisms to help people who can't. So generally, I think there is sort of a delivery understanding of what you do and how you do it. Now, I'm going to challenge you. Next question is focus on the question of smart healthcare. You've already spoken a bit about it, but practically in Pakistan, what does it mean? When you're looking at a smart hospital, what are you thinking about as a chief executive of how are you going to implement these smart hospitals? One aspect you've all talked about is electronic health record. Absolutely key. What else are you doing in your organizations from a Pakistan perspective? And one thing I just want to caution as well is I hear a lot about all the things we want to do, all the wonderful things that are out there. In Pakistan, patients will not be able to afford it. There's already an issue. So speak practically from your hospital perspective. Let's start again, if you don't mind, Dr. Farad, since you're sitting there, and we'll just go down the line. What exactly does smart hospital mean to you? And how exactly do you think you could put systems in place that are effective and affordable?
Thank you, Salim. And a beautiful summarization of all the panel's input and how you have really captured the scene. So coming from there, I think from an institutional perspective, organizational perspective, let me give you the scenario, what you're thinking. So we are actually focusing on developing and further enhancing so-called the integrated health system. Now, there are different definitions now you call integrated health system, how the whole system works. I think if you look globally, there are many countries in which you see a better integrated system as opposed to many other organizations and many other countries and many other areas where you see everything completely standing in silo and not connected to each other. So from AKU perspective, what we are trying to do is essentially, we're looking at two things. One is from our own structures and existing facilities. What we want to do is essentially create a spine of connectivity, which is the core functions, the support functions, essentially in such a way that everything works in tandem with the focus that will be patient-centric. Number one, patient-centric, and second thing is it provides continuity of care. So your entry point into a health system could be anywhere. Your movement through the health system could be based on your health needs. If you require primary, you require secondary. Interventions could be done at different levels. If you need to go to a tertiary and quaternary, you need quaternary care, you move to a system, then you go back to your system. Now, it's not easy. It's very, very difficult. It's not easy to do. So what we are trying to do here, technology will be a huge component. Essentially, technology will be the foundation which will help us. So you talked about electronic health records. We're massively investing into electronic health records, not only in Pakistan, but adoption. East Africa has already adopted it. And we'll have across wherever the AKU health system is existing, we'll have an electronic health record which is connected to each other. Now, what does it mean? It means that your health record and your health information is accessible everywhere as you move along. So it's not restricted by geography and boundaries. The second thing is, if you, from a primary, secondary, tertiary, quaternary care structure, and you start also you talked about affordability. So we are also looking at segmentation or segments of societies. Are we going to serve only one segment or two segments or three or four segments? And you can have, the segmentation could be all the way from the most destitute, extremely poor, all the way to the extreme rich. We are totally committed, and that's what we've been doing all along, is serving all segments. Now, when you serve different segments, what essentially is the care part remains the same. The hospitality part or the requirements of the various health systems structures which you create may be different. So what you do, you have to make sure, you very much mentioned it clearly earlier as well, it has to be affordable, it has to be cost effective, at the same time high quality care, across every segment which you serve. So for that, you really have to put in a lot of interventions and a lot of systems in place, and building upon a lot of work which has been done in different parts of the world, in Pakistan, in public sector, in private sector, governmental sector. I think a lot of focus has gone into creating public health, population health perspective. Now, how do you take public and population health, some of the key initiatives, and implement into a health system? And if you do that, that first of all provides you a controlled output, standardized care. At the same time, you ensure you bring down your cost of care tremendously. And what do I mean by that? So, you know, in Pakistan, if you see, there are about maybe 20,000 different medications which are available. The option to treat one simple thing could be from a 2 rupee pill to a 2,000 rupee pill. How the evidence-based best practices which ought to be put in place. So if you do standardized care, you control that what for different areas, what medications you would be using, what kind of standardized care patterns you will be. So you control the physician practices in the communities and they get the same controlled care. You connect the entire system all the way through, that if a specialized care is needed or an input is needed, technology can help you to connect with, and you move patients along. So, sorry, long-related answer to your question. What we are essentially trying to do is create an integrated health system, providing all segments, helping all segments of society, continuum of care model, from the far-flung to the tertiary care, and ensuring that the movement happens back and forth. Thank you.
And if I can request panelists again, thank you. If I can request panelists, a 3-minute, but speak to the smart hospital issue, technology.
Thank you, Salim. I think Dr. Farid Abbas has spoken about all our AKU, what we all are doing across the geographies. But one thing is also very important, that when it comes to AK, the Aga Khan Development Network has a much larger footprint across the globe, our sister concern, Aga Khan Health Services. So currently in Afghanistan, we are working in 5 provinces which are completely being owned by AKDN and providing care to millions of the patients every year. So what we are looking in is technology which can help integrate all this, and also it will help us that how we can provide a seamless care where the physician is engaged, patient is engaged, and also the system is engaged. So when, I'll give a small example, that we established initially the e-health in different parts of Afghanistan. After seeing 50,000 patients, we did a cost calculation. How? So we saved around $12 million on that. Salim is here. So sometimes we always say, okay, it is very expensive, but I think it has we need to see down the line for some time what it is. When you are talking about a health system or a hospital individually, it may be a different scenario, but when we are talking, so I'm looking for a tool which will be helping my physicians, my patient to talk to each other and also keep their records so we can always communicate to each other. Currently, we are doing a hub-to-hub consultation, but our aim is to go beyond that, apart from the hospital systems, that how we can hub and individual patients can be communicating to each other and bringing that information and also creating some evidence-based practices. As currently, we all are referring the data to the Western world. I think we have our own issues. So my last thing is, one of the infectious disease consultant came from France to Kabul for 3 months, and he said, Aziz, I'm an expert on this tuberculosis. I said, how many patients you see in a day? He said, I see 1 or 2 in a month. I said, my consultant is seeing 20 to 25 patients every day. So look at the difference. So I think that is what we are looking at, how we can generate our own sources.
Thank you.
Thank you First of all, I will just put some comments on the EMR. Unfortunately, in Pakistan, the hospitals don't share data with each other. So we have to come up with an out-of-box solution. I had a meeting with Nadra people. They came to us because they wanted direct reporting of births and deaths directly into their system, so they were integrating with us. So our national ID card is a chip-based, and there is a lot of spaces there. The patient data is the intellectual property of the patient. So I asked them, why can't we have a patient data, every individual patient data on that chip? Wherever he goes, you just put in the ID card, and people, wherever in any hospital, they can see the data, and whatever they have done, they just put in, so it is there. So they are going to look into that. We all talk about the patient-centered, 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 but it has to be people-centered. The physicians giving, the paramedics, and it is a teamwork. Now about the smart hospitals, so we were paperless since we started in 2007. The module has changed. Now version 2 is there, version 2+1 is there because we have learned a lot. The major problem in Pakistan is trained human resources in ICU care, in emergency medicines. So what we do, we are running about 15 hospitals across Pakistan. Some of them are in the rural part of Pakistan where you don't get trained doctors. So what to talk about the consultants or emergency medicine physicians. So in 2 hospitals, in Gawadar and Badin, we started a tele-emergency. It's 24/7 from Karachi, the consultants in there. The whole emergency department of that hospital can be seen here. We have a common electronic medical records. We have the data we can put in, we can guide them. And it has proven very successful because we have saved many lives. Then telemedicine in remote parts of Pakistan where you can't go. So you have to have telemedicine. So we have telemedicine. So why it is cost effective. Unfortunately, the finance people doesn't realize it unless you have a data, you have a pilot, and you prove them. Then it becomes easier. And when you have a board where you have different ethnic, it is very difficult to convince them. And if you have women in that, then it is the most problem. Thank you.
Thank you.
I think I will not talk about a perspective of one hospital. I'll talk about the perspective of a regulator. Whenever you want to build any smart hospital, you have to look at 3 things, which is the structure, process, and the outcome. The structure is a part which a person can do whatever he likes and whatever he has got finance for. The main part is the process, because if this digitalization of the hospital system in some way get away from the personal communication of the physician to the patient, this will be a problem. So it has to incorporate those processes which are very necessary for patient care way back from the inception of this world. It is necessary that there's a human touch which is required. So even if you have digitalized, this human touch you cannot miss. So after process, that's outcome. As a regulator, how many private hospitals are ready to share their processes data and outcome data with the regulator to regulate them? Very difficult. Very difficult. So anything where data is not being shared transparently to the regulator, it will become difficult for the regulator to allow something to happen. So there has to be a bridge between the regulator, the required standards, and all those processes which need to be established in any hospital setting. So these are 2 very important aspects from the regulation point of view. Out of 300 complaints which we received in the last 2 years at the Commission, and it correlates with the data which is already available internationally, that more than 80% complaints do happen in a hospital setting, not because of any negligence but because of lack of communication and because of lack of documentation, which converts into negligence, which reflects as negligence, which reflects as something bad done by a doctor. But it is the complex matrix of the system of the hospital where there are so many cracks from which things got fall down. So having said that, for any smart hospital, these things have to be taken into account, that how your structure is and what you're incorporating as a process. Process is my passion. The process has to be the right. When your process is right, your system will be right. And your process should not be oblivious of the needs which are basic patient needs of human touch, compassion, passion, empathy, communication, and documentation. And then outcome sharing data with the regulator. Thanks a lot.
Thank you.
Yeah, just to quickly touch upon the point of sharing of data and its significance. We've got silos within the healthcare system, within a given hospital, and there are silos within the wider ecosystem as well. And I think there's a long way to go on overcoming that, and ultimately the goal should be, a national level platform where the data is shared. We, on our part, are working very closely with the providers within our city and within our province, both public and private, to see if you can take a start somewhere. It's great to have some very ambitious goals, but if you can just start somewhere, and I know there are trust issues over there, and there's so many other factors that result in this not happening, but even if we take a very modest start, to see what is it that we can share for the patients that are going through the system, I think the results will be phenomenal. The kind of duplication that is happening when a patient visits more than one facility, how the quality of care is compromised and so on. So that's something that is very much actively on our roadmap right now. With regards to our vision for the future in terms of a smart hospital, and looking at it more from the patient's perspective, I think COVID was a great reminder for us to see on what care could be delivered outside the hospital. And that's where telemedicine and things like home services really took off. It's slightly reduced since then, but still patients now realize that for a lot of the services that they were formerly visiting hospitals for can now be delivered at home. And going forward, we see even more services that could be delivered outside the hospital setting. The future smart hospital, from the patient's perspective, we're looking at a number of interventions, but we would generally want to evaluate them according to a few criteria. The first is clearly inclusivity. We talk about the digital penetration and the population that is, on smartphones and everything, but how many patients can really interact with all of these technologies and benefit from all of these technologies? And it's not just about literacy, it's not just about language, it's the culture, it's the mindset. The second part, as you mentioned, is affordability. There's a host of innovative solutions and technologies available out there that you could adopt, and they're fantastic. You could do wonderful work with it. But at the end of the day, is it affordable? The segment that you're choosing to serve, can they really benefit from that? Can they really afford that or not? We've spoken a bit earlier about the engagement aspect, the patient experience aspect. All the repetitive tasks that could be easily delegated to all of these new systems that are available, how artificial intelligence and machine learning can support that. If at the end of the day, it frees up a caregiver's time to interact more with the patient, empathy is something that technology cannot, in the foreseeable future, take over. But if that time is being freed up to improve the kind of the quality of encounter that patients are having with the caregivers, I think that the smartness of the hospital from the patient's perspective is, where it's really accessible, where it's affordable, where it improves that experience, and where it's really personalized. I was reading a book some time back. It's called The Patient Will See You Now. It's by Eric Topol. And it all talks about this whole dynamic shift that has happened. Traditionally you had the physician here and you had the patient here, and it was just a top-down relationship. And now everything being centered around the patient, who's far more empowered, who's far more informed. So that is what they're demanding now. I mean, we've seen the impact of technology on the banking sector, on the mobility, on hospitality. Very few of those benefits as a nation have come on to healthcare so far. So we need to rationalize the kind of goals that we want to go for. We need to optimize them according to our setting. And for that, I think inclusivity, the patient experience, personalization, and affordability are key aspects which we use to evaluate what kind of interventions we can take on board.
Excellent. Thank you. So we'll take a couple of questions. I think this last portion, again, you heard about issues of integration in terms of smart hospitals. You looked at all the issues that regulators have in terms of transparency of data. You've got examples of exactly how the many touch points really need to come to compassionate care. Now the patient actually, interestingly, is at equal in terms of information need and access in terms of understanding. So that is something we all have to integrate into our thinking in terms of smart hospitals, right? You've got smart hospitals, now you've got smart patients, interestingly, right? We'll take a couple of questions. Yeah, I'm sorry, we'll have to go at the back there. Yeah. We'll take a couple. Just keep it brief, please, and introduce yourself.
Yeah, my name is Amin Himani. First, I would like to thank the elite panel for their insight. Mine is not a question, just a little comment. You know, when we think of the word smart, the first thing that comes to mind is technology. But technology is not the only thing that we should consider. I mean, smart means smart workflows as well. Not just technology. I'm not undermining the need for technology. I dare not in a health tech conference. But you can have the top of the line gadgetry and have a not so smart workflow to go with it, and it'll just kill the purpose. So while we are focusing on technology, when we speak of smart hospital, we should not lose focus of the smart workflows that goes along with it.
Yeah, thank you. And again, we should remind ourselves, yeah, we should acknowledge that. Thank you. Yesterday, we talked about that. Sayani talked about technology as an enabler. So I think that's pretty universally accepted, that technology is going to be an enabler. We talked about structure, process, outcome right now. Process in terms of technology is going to be crucial. So workflows are just as smart. Technology is just as smart. Technology is going to be an enabler. So important point. Thank you.
Salim, can I?
Yep, sure,
yeah.
please.
So my name is Syed Mohammad Sohail and I work here at AKU. First of all, thank you for this August panel, sharing their experiences. Salim, I'm reading this as creating bestest patient experiences, not only optimal patient experiences. One dimension that was not referred so people didn't allude to it, and I just want to request their thoughts on it. Patient-centered care got referred to, Plane Tree got referred to. There is a chapter in Plane Tree standards that says care for the caregivers. I think one missing element that I see is that we are interested in knowing the experience of a patient who has come today, may not come for a year even. And we have caregivers, and they're not only doctors and nurses, they are the gardeners, they're the housekeepers, they're everyone drivers. What do we do in making them happy? Kenneth Blanchard mentioned that in his Raving Fans. You take care of your people, forget your customers, they'll be very well taken care of. So I think that needs to be also alluded. I mean, just said smart workflow, smart people, and smart people means engaged people. And when they are not engaged, what do we do so that they then follow that process that Asan was referring to? They will then contribute to improving those processes and outcomes. So I think this is a dimension that needs to be given importance as well. Thank you.
Does anyone want to add to that? Yeah, well taken. I mean, at the end of the day, why don't you respond to that, please?
I told you that because it is the people-centered. So you have to take care of your caregivers and everything. The other thing which is important is why they are doing it. Because if you say a housekeeper that he wants to keep it clean because his supervisor is monitoring him, actually you have to tell them this work is contributing patient going healthy home. Then the dynamics will change. Yes. So you have to, everyone has to know why they are doing it.
So I think that summarizes, I think that's a good summary in terms of, and we're not neglecting it. When we talk about people-centered care, we're talking about the caregiver and everyone, including the patient, right? So it's the ecosystem, the complete. And the other one comes down to acknowledgement, as we discussed, taking care of your own people. That comes back to creating the culture in the organization. We won't have time to discuss all this, but when you're setting your standards, like some of you talked about standards, part of standard setting is what? Setting standards such that you look after the mental well-being of your employees. make sure they're taken care of, train them, right? So I think that's a very important point. We'll take one last question. I know I'm a bit over, but is there one more? Yeah, please go ahead.
Assalamu alaikum, this is Haris Vaib. First of all, thank you so much, all of you. That was really insightful. My question is to Dr. Hassan, who talked about the missing elements in the curriculum. So I'm a non-technical person. I'm not a doctor by profession. I've never studied medicine. I'm an MBA. हमारे MBA के अंदर जो है बहुत ज़्यादा communication और चीज़ों को पढ़ाया जाता है. And what I figure from Dr. Hassan Qayyum's observation is that it's the missing element on the medical side. So what have we done about it? I mean, I think we are in the 8th decade of our independence. What have we done about it? And अगर नहीं हुआ अभी तक तो क्यों नहीं हुआ? Who's responsible for that? Thank you.
Okay, thank you for the question. And I think the first thing to move towards any solution is to recognize the problem. So this problem is now very blatantly being recognized. And when we see that these are the elements which are incorporated later on, because when I was studying in my medical school, I was never told about communication as such, as a separate subject. I was never told about infection control. I was never told about these all things, quality, what is quality. So these all things came in when I was a graduate and even a postgraduate. So then the whole think tank realized that this is happening, and this is the problem, that's the reason the doctors are the most difficult entity to practice infection control. They are the most learned, but they are the most difficult entity to practice infection control. Nurses are the most easy entity to practice infection control. Why? Because in nursing curriculum, it was part of it. So now what you're saying, many medical schools, including AKU, I know, they have already included these things into their curriculum. But it is still not available universally. So this is a need. I agree with you. Thank you.
Thank you. I'm so sorry. I know there are lots of questions, but we'll have to cut it short at this stage, so I do apologize. Thank you all for being here. I really want to appreciate the panel here. You've got, the chief executives of the premier institutions in Pakistan, something you should be very proud of. So please acknowledge them for the panel. Thank you.